Hello and welcome to TiCME, time-critical medical education. My name's Dr. Nick Taylor and I'm an emergency physician based at the Canberra Hospital. Today's tutorial is one of our TiCME Plus series, so slightly more advanced, and it's all about narrow complex tachycardias. This is part of a pair of talks which includes wide complex tachycardias as well. Remember when you watch this movie that at any point you need more time to look at an ECG, you can just pause the movie. Okay, let's start off with a familiar case. 71-year-old lady comes into the ED via ambulance, complaining of palpitations and dizziness. The ambulance give you a rhythm strip, and unfortunately when you look at it, you're not quite sure what's going on. You need to answer two main questions. Do you need to act now? Is this so important? Is the patient so unwell you need to do something immediately? And secondly, how do I work out what's happening? Hopefully by the end of today, we'll have given you enough information so that you can answer these two questions. Initial approach to anybody with a tachyarrhythmia is very simple. Firstly, is the patient stable or unstable? Next, are the QRS complexes wide or narrow? And finally, is the rhythm regular or irregular? First things first, if the patient is hemodynamically unstable and you think the tachyarrhythmia is the reason behind the instability, think cardioversion first and diagnosis second. You shouldn't be waiting for an hour and a half for test results to come back if the patient's blood pressure is 60. Next step, are the complexes wide or narrow? And today we're going to talk all about narrow complexes. Okay, so before we move on to narrow complex tachycardias in detail, I want you to very briefly understand the conduction pathways. To help you do that, I've drawn this simple schematic which looks, I know, like a bit of a smiley dog face, but keeping it simple helps to understand things. Narrow complex tachycardias occur when the signal is originally generated above the ventricles in the node, the AV node, around the AV node, the atria or the sinus node, and then the signal is conducted through the AV node and through normal bundles of His, so that the signal spreads rapidly through the bundles, the superhighways of conduction, into the ventricles. The time frame for ventricular depolarization is short, so the QRS complex is narrow. Wide complex tachycardias occur when the signal is generated in the ventricle, and so the ventricular depolarization takes longer, not going through the AV node, or when any of the supraventricular rhythms are transmitted via a delay in conduction. So there could be a bundle branch block, for example, which will then take longer. So a supraventricular rhythm with conduction delay in the ventricle, or a supraventricular rhythm reaching the ventricle via an accessory pathway, and the accessory pathway will depolarize the ventricle from out in the ventricle somewhere, not using the superhighways, so it will again take longer to depolarize and become a wide complex tachycardia. Okay, so we're going to go in great detail on all the sorts of narrow complex tachycardias. Let's make a start. When we look at our narrow complex tachycardias, we first of all need to decide whether the rhythm is regular or irregular. Next, we need to decide whether there is a P wave or not. And when we look at the P wave and we find one, we then have to decide whether there is a long or short RP distance. Now, we're going to talk about this in far more detail later, the RP distance, but it is a helpful way of working out some of the more complex P-wave associated rhythms. Okay, so let's look at our first irregular narrow complex tachycardia. Be happy enough looking at the baseline that it is definitely irregular. If it's irregular, we need to decide whether there are P waves or not, and you do see some fluctuations up here that may be P waves, but if we look along the rest of our rhythm strip, I think you agree there aren't any regular P waves which are associated with the QRS complex. And the final question with this rhythm is the baseline regular and isoelectric, or is it moving around? And the answer is there's no isoelectric period in the baseline. It appears to be uneven. So this is very simple. This is paroxysmal AF. So atrial fibrillation has no P waves and is irregular. It's caused by multiple things, including electrolyte disturbance, structural heart disease. It's often post-cardiac surgery. In patients who don't have any underlying cause, particularly the younger patients, it's known as lone AF. Now, the atrial rhythm in AF is rapid and irregular, and it shows low amplitude fibrillatory waves, and that gives the appearance on ECG of having a non-flat or no isoelectric period in the baseline. Usually it's formed because of a reentrant circuit within the atria, but very occasionally, and often with people who are more of the lone AF variants, there is a single ectopic focus which during EP studies can be identified and occasionally successfully ablated. Treatment of AS is often just treating the underlying cause, so to correct the electrolyte disturbances or treat the patient's thyroid disease or make the pneumonia better. And then obviously there's discussion needing to be had about whether the patient's for rate or rhythm control, and if they're for rhythm control, what time period is suitable, and whether you use electricity or drugs. And that's not going to be the focus of our talk today. Let's look at our next example. Again, start by having a look at a baseline. Here it's V1. Again, if you follow across, you can see it is definitely irregular. So the next question, are there P waves? And the magic arrows are pointing to things that look like P waves. When we look at P waves, it's really important to look at their morphology, and if we think something's going to be sinus rhythm has the same morphology P wave and the same PR interval within each lead. So if we look at these P waves, I think you'll agree that they look different. They're of different heights and different widths, and the PR intervals differ between each one. So what we have is a narrow complex irregular rhythm. There are P waves, but the P wave morphology differs and the PR interval differs. Also what happens is the PP interval differs. So here's quite a long PP interval and here's quite a short PP interval, and that's causing the variation in RR interval, which makes the rhythm irregular. Do you know what this one is? So this is multifocal atrial tachycardia. It's commonly found in elderly patients, particularly those with underlying lung disease, probably because they get high pulmonary pressures, which causes right atrial stretch. Also found in hypomagnesic patients, such as alcoholics. It's defined as having 3 different P wave morphologies with varying PP and PR intervals. There is an isoelectric period on the baseline, and that means it's not AF. Okay, here's our next example. Let's have a look at the baseline to start with. Again, it appears to be irregular. There appears to be a pattern of regularity within the irregularness of this baseline, however. Remember, if we're going to have an irregular rhythm, we first need to decide whether there's P waves. If you're not certain by looking in your rhythm strip, the best place to go looking is in lead V1. So what we're seeing here in the isoelectric period are blips in the line that look like they might be P waves. So the question is, are these P waves causing ventricular depolarization or not? And one of the best ways to tell, first of all, we look at morphology, and if we look at each of these P waves here, they do look to be quite similar in morphology. However, there appears to be more P waves than there are R waves. So that tells us whatever's going on, there must be some block at the AV node, as not all P's are conducted. And the next question is, what is the rate of the P wave? Now remember that the sinus node really can't go above about 220, 230 beats per minute. Remember, the AV node won't conduct more than about 220 minus your age. So we have a look at the rate of these blips. They're going about once every big square, once every 200 milliseconds, What does that work out to be? Well, that's 300 times per minute. And once you see that there are regular blips at 300 times per minute, the diagnosis becomes quite obvious. So this is atrial flutter. These are flutter waves, and there is variable block at the AV node. So we have 2 to 1 block, and then 4 to 1 block, 2 to 1 block, 4 to 1 block. So remember, when you're dealing with atrial flutter, that the flutter wave rate is often around 300. Now it can vary from as low as 260 if people are on rate control drugs, and I have seen one with a rate of 360. So flutter can vary from 260 to 360, and remember that the QRS complexes will be a multiple of this flutter wave rate. So the flutter waves will be a constant distance apart, and the R interval will be a multiple of the PP interval or P rate. Here's our next example, and if we have a look at it briefly along our rhythm strip, the first impression is it looks quite similar to our last ECG. So it's irregular, but there's a regular component to the irregularity. Next question is, are there P waves? And there are looking like there's P waves before every second QRS complex. The morphology of these P waves looks to be the same within the lead, and the PR interval looks to be constant between each beat. But then we've got extra beats. Now they look similar morphology to the QRS complexes that precede it. So they're narrow, so they're definitely going through the AV node, but it doesn't look like they're coming from the sinus node. So these are now early beats without P waves. So these are atrial ectopics, or supraventricular ectopics. So this rhythm, as there is one ectopic for each normal beat, is supraventricular bigeminy. So again, a cause of irregular narrow complex tachycardia can be sinus with atrial premature complexes. It's important to look for a regular pattern, such as bigeminy here. It doesn't require any specific treatment. It's due to increased atrial automaticity, but as we'll learn later, atrial ectopics can trigger SVT if you're susceptible. So let's summarize irregular narrow complex tachycardias. If there's no P waves and no isoelectric baselines, it's likely to be AF. If there's varying P wave morphology, PR intervals and PP intervals, then the diagnosis is multifocal atrial tachycardia. If you see flutter waves, and to confirm the RR interval is a multiple of the flutter wave rate, then you have flutter with variable block. And remember, if you're seeing extra narrow complex beats, you probably have atrial ectopics. Okay, let's move on. We're going to talk about irregular narrow complex tachycardias now. And remember, once we decide it's regular, the next step, look for P waves. When we look at P waves, we need to look at P wave morphology. We need to decide whether the P wave is upright or inverted. And just to explain that, in a lead which normally has upright P waves, it tells you that the direction of depolarization is usually from the sinoatrial node down towards the AV node. If in that lead you're actually having inverted P waves, it's because the direction of depolarization is backwards, which tells us that the site of the depolarization has probably started from somewhere near the AV node. We're going to look at the RP distance, which I'm going to talk to you about in a second. Remember that P waves can hide in QRS complexes in the ST segment, or sometimes even in the T waves. And remember, as we said before, that lead V1 is the best for P wave hunting. Okay, so we're going to introduce probably a new concept to you today. This is the RP interval, and it is a way to classify narrow complex tachycardias. Now, you might think, why do I need to do that? Reality is, most of the time you don't need to. However, in the more difficult supraventricular arrhythmias, the RP interval can be very helpful. Let's summarize for you. There is an RR distance and we're going to look at approximately the halfway point. Okay, then what we do is we measure the distance from the R wave to the P wave. This is called the RP distance. Obviously it differs from the PR interval. The RP distance is then classified based on whether it's more than halfway to the R wave or less than halfway to the next R wave. So let's have a look. There's a P wave here. The RP distance is less than halfway, so this is called a short RP tachycardia. What this implies is that the signal to depolarize the atrium is coming from very close to the AV node or within the AV node, because the ventricle and the atria are being depolarized at almost the same time. Then we have this next example where the P wave is more than halfway between the R waves. So this is a long RP tachycardia, and what that's telling you is that the depolarization is essentially occurring in the atria or in the sinoatrial node. Okay, first really easy example of regular narrow complex tachycardia. Let's start, look at our baseline. What have we got? Nice regular rhythm. Are there P waves? I think you'll agree the answer is yes. There's a P wave before each QRS. In the lead, is the morphology of the P wave the same? The answer is yes. And are the PR intervals the same? The answer is yes. The next question is the RP distance short or long? Well, from the R wave to the P wave is more than 50% of the R interval, so this is a long RP tachycardia. As we said, this now means that our generation of atrial depolarization is coming from either the atria or the sinoatrial node. This looks normal and regular, so this is sinus tachycardia. Now, sinus tachycardia is usually caused by an underlying medical condition, such as pneumonia, such as blood loss. But there are some standalone diagnoses. The most common one is called inappropriate sinus tachycardia, and that's more often found in females and healthcare workers. And you find this on Holter monitor when people are getting palpitations or feelings of tachycardia, because you get a sinus rate that's high during the day, but when the patient sleeps at night, it's back down to normal. The other one is known as the postural orthostatic tachycardia syndrome, and these patients get an inappropriate sinus tachycardia when they stand up. The important differential is an autonomic dysfunction such as sympathetic neuropathy in diabetic patients, and there is no postural hypotension in these patients. Okay, let's look at this next ECG. It's a regular narrow complex tachycardia. Because it's regular, we're looking for P waves, and there are P waves before every QRS complex. Now that we know about RP distance, we're going to look at the RP distance, and because the P wave is more than 50% of the way from the R wave, we know this is a long RP tachycardia. Now remember that long RP tachycardias essentially consist of sinus tachycardia and atrial tachycardia. How do we tell the difference? Well, first of all, clinically is most important. The onset and offset of the rhythm is very important. Sinus rhythm will speed up and slow down gradually, and will also be influenced by factors related to the vagus and the sympathetic system. So if you have pain, or you're short of breath, or you're moving, your sinus rate will vary. Paroxysmal atrial tachycardia tends to come on very suddenly, so if you're at a baseline of 70 and shoot up to 144 all of a sudden, then you'd be worried that it might be atrial tachycardia. It will also turn off rapidly as well, without slowing down. And often, the rate of atrial tachycardia will be varying on the monitor. Now, the other factor we need to look at, apart from clinical factors, are morphology of the ECG, and the P wave in atrial tachycardia tends to come earlier than it would in sinus rhythm, because they're essentially atrial premature beats, and so you can see here that the P waves are occurring on almost on the back of the T waves. The other thing, that the morphology of the P wave will be different to in sinus, because the location of the depolarization inside the atria is different, so the P waves will look different. If you're lucky enough to get someone who has atrial tachycardia and reverts to sinus, then compare the morphology of the P waves. Atrial tachycardia is the third most common form of supraventricular or narrow complex tachycardias. It makes up about 10%. It usually arises from a localized focus of atrial tissue, and the locations are characteristic. So when you go and have EP studies, the P wave morphology can be used to identify the site of the tachycardia origin. These rhythms can actually sometimes terminate with adenosine. They commonly are found when there's an underlying other medical process going on. So atrial tachs are quite common in patients with underlying pneumonia, for example. In that situation, they generally don't cause any trouble at all. You can treat them with beta blockers or calcium channel blockers. And remember, the ventricular rate will be dependent on the amount of AV nodal blockade. Well, there's never a bad time to talk about the cardiac action potential, and hopefully today, by learning a bit about it, you'll be able to learn why the AV node blocks signals, why some cells act as pacemakers, and also how some arrhythmias are generated. The cardiac action potential is formed with 5 main phases. Phase 4 is the resting membrane potential. Phase 0 is the rapid opening of fast sodium channels, causing influx of sodium into the cell and the main spike of depolarization. Phase 1 is when potassium channels open and potassium slowly starts leaking out of the cell. This continues into phase 2, but also calcium channels open and calcium slowly leaks into the cell. At the end of phase 2, the calcium channels shut, but potassium continues to exit the cell during phase 3 until we're back to the resting membrane potential. If we look at the ECG during the cardiac action potential, the QRS complex is formed from this big spike of depolarization in phase 0, and the T wave is formed during repolarization of the ventricle as potassium exits the cell in phase 3. Now, in between phase 0 and phase 3 is the absolute refractory period. Absolute refractory period means that you cannot depolarize the cell again, and this is because the sodium channels are shut. Now, in phase 3, some sodium channels become available, and what happens here in the relative refractory period is a supramaximal stimulus can cause a depolarization. This explains the R on T phenomenon. When an R wave or a ventricular depolarization occurring on top of a T wave can provoke VT or VF. Now, why do some cells act as pacemakers, such as the sinoatrial node, the junction around the AV node, atrial cells, and ventricular cells? Well, these cells have different properties to the normal cells in the myocardium, and these cells actually have spontaneous depolarizations, and this is caused because potassium slowly leaches out of the cell. The fastest spontaneous depolarizer becomes a pacemaker, which in normal business is the sinoatrial node. What about the AV node, and why does it cause block of atrial signals to slow down the rate to the ventricle? Well, this is due to inherent properties within the AV node. Firstly, there's a lot of internal resistance, mainly due to the fact there's very tight gap junctions between the cells. The other thing is that the absolute refractory period is much longer in the AV node, so it won't depolarize as easily as other cells. My theory is that this is an adaptive human genetic thing which occurred when we were proto-humans. Now, AF is a very common rhythm, and people who didn't have these properties in the AV node, if they got AF, essentially they'd end up with VF. So they'd all die out, and we got left with humans which have properties of the AV node which are helpful to us. That's my theory anyway. Okay, so let's look at this next example. I think you'll be absolutely clear that this is fast and narrow. Now, if it's regular, which it is, and narrow, we look for P waves, and I think on an initial scan you'll say, look, there's no P waves. Most of you would probably call this rhythm SVT. I'm going to talk about how we can subclassify what you know as SVT into its actual causes by being a bit clever with the little P waves that we can have a look for. Now, if we have a look up in V1, you see that there's an R wave followed by an S wave and then another little blip, second R wave known as the R prime wave. If we look down in lead 3, there's a small Q wave followed by an R wave and then another little blip which looks a bit like a small S wave. Now, this rhythm is actually called AVNRT, or AV nodal reentrant tachycardia. If you trust me for a minute, and I'll tell you that this small R prime wave and this small S wave are actually P waves, then you can see that the RP distance is short. So this is a short RP tachycardia. Let's learn about AVNRT in a little bit more detail. So AVNRT, or AV nodal reentrant tachycardia, is the most common of the paroxysmal SVTs. It's about 90% of them. It happens because within the AV node there's fast and slow conducting limbs, and usually you conduct antegrade down the fast limb. Now, antegrade means in the direction from atria to ventricle. Retrograde means in the direction from ventricle to atria. So typical AVNRT is initiated when an atrial premature complex blocks in the fast pathway and then conducts over the slow pathway. Now, when it gets to the bottom of that slow tract, if the fast pathway has recovered its excitability, the impulse conducts retrogradely back over the fast pathway and then depolarizes the atria backwards, resulting in an atrial echo. If the impulse re-enters into the slow pathway, you initiate AVNRT, and so the cycle just goes round and round and round. That atrial echo causes a P wave. Now, the P wave won't look like a regular sinus P wave. It will usually be small and upside down, so it's been a retrograde one. They're usually buried in the QRS complex because the atria and the ventricle are depolarized at the same time, and they manifest as pseudo S waves in 2-3 and AVF and pseudo R waves in V1. Now, remember that if you're going to treat an AVNRT, it'd make sense to try and block the AV node. So we start usually with vagal maneuvers, and probably the best thing is to lie the patient flat. Supine is a better rate of conversion if you're supine than sitting up, and we usually get people to blow into the inlet of a 20mm syringe and try and blow the plunger out. That usually works. If not, you can try adenosine, and remember that adenosine makes people feel absolutely awful for about 10 to 30 seconds. You need to warn them of that. And if that fails, the third line is verapamil. Now, caveat for verapamil, which is very effective in terminating paroxysmal SVT, is it's a long-acting negative inotrope. So if you have doubt about your diagnosis, if your patient's really unwell, or if they've got an underlying very sick heart, then we'd usually completely avoid verapamil and go to direct DC cardioversion. Okay, so we've done AVNRT, and remember I said that 10% of paroxysmal SVTs are something else. So we look at this example. We're seeing these little pseudo waves again. Now, these are P waves, and if we have a look at the distance, they are still inside the 50% RR interval. So if we're measuring the R to P distance, it's still short. There are other little deflections in the baseline here, which with the eye of faith we'll call P waves as well. Probably best seen in AVL, this little deflection down here. So what we've got is slightly more time has elapsed from the QRS complex to the atrial echo. Certainly that atrial echo is not causing the QRS to form because it's within the first half of the RR interval. This is a narrow complex regular tachycardia still, but the RP distance is slightly longer than we saw when it was buried in the QRS complex. So this is the second type of paroxysmal SVT called atrioventricular reciprocating tachycardia, or AVRT. And in this situation, an accessory pathway connects the atria to the ventricle. Impulses can travel down the AV node but re-enter via the accessory pathway. When this happens, it's normal direction and it's called orthodromic AVRT. Most people with an accessory pathway can only conduct up from ventricle to atria, and when they get a tachycardia they get orthodromic AVRT. Now, impulses can travel down sometimes the accessory pathway but re-enter via the AV node, and this is opposite to normal, so this is known as antidromic AVRT, and that's about 5%. And we'll have a look at the particular sort of antidromic AVRT known as WPW a little bit later. Okay, so I'm going to help you understand accessory pathway conduction now graphically. So let's look at what occurs in normal sinus rhythm. So this is in a patient with Wolff-Parkinson-White. In normal sinus rhythm we have signal generation above the AV node. It's conducted down the AV node, but it's also conducted down the accessory pathway, causing ventricular early depolarization, which is the pre-excitation phase, which is a short PR interval and a delta wave. If we set up a reentrant tachycardia using the accessory pathway, the first sort is called orthodromic or standard direction. The signal comes down the AV node but then is allowed to re-enter via the accessory pathway. So this will form again a narrow complex tachycardia because we're going through the AV node and the bundles first, but it's re-entering via the accessory pathway. And finally, the dangerous sort is called antidromic AVRT. Why is this dangerous? Because instead of coming down through the AV node, and remember the rate will be limited by those inherent properties of the AV nodal region, the signal gets transmitted directly down the accessory pathway, and the accessory pathway does not have rate limiting components to its depolarization and refractory period. So whatever the rate is in the atria will be transmitted one-to-one to the ventricle, and then we re-enter via the AV node and back again. This is a dangerous rhythm. This is antidromic AVRT. It's usually broad complex because the ventricle has been depolarized out wider, and so it takes longer to depolarize the whole ventricle than it would if it was depolarized via the bundles. Okay, so let's talk about AVRT and Wolff-Parkinson-White. Wolff-Parkinson-White syndrome exists when in the resting ECG the ventricle is simultaneously depolarized via both the accessory pathway and the AV node, causing ventricular pre-excitation. So the atrial signal not only goes down the AV node, it goes down the accessory pathway. Now remember what we said, the AV node and the proximal bundle are a bit slower to conduct, so the signal reaches the ventricle faster when it goes down the accessory pathway. So the ventricle starts to depolarize earlier, and that gives you a short PR interval, and it depolarizes not down the bundles. So instead of getting a nice regular narrow QRS, you get a slightly wide QRS with a slurred upstroke, which is the delta wave. Being able to conduct from atria to ventricle gives us the potential for antidromic conduction of an arrhythmia. Now remember, when a signal goes from atria to ventricle via the accessory pathway, it can get there faster than if it goes via the AV node. If you do not have pre-excitation, so a delta wave or short PR interval on your resting ECG, then your accessory pathway is said to be concealed. Okay, so let's look at an example of this here. It's a regular narrow complex tachycardia. We look for P waves, and in fact, now that we're getting a little bit better at spotting them, we think that there's a funny little blip down in here, that there's a funny little blip here after the T wave or in the T wave, and again here. So these are probably pseudo R prime waves and pseudo F waves that make us think of P waves. And again, it's a short R to P distance because it's inside the halfway mark. Now, it's a narrow complex, which makes us think that this is almost certainly going to be an orthodromic AVRT. The proof is in the sinus rhythm ECG, And again, we have to look for evidence of pre-excitation, such as what you get in Wolff-Parkinson-White with the delta wave. Now, the person that this ECG came from in sinus rhythm didn't have any ventricular pre-excitation. That means that you cannot tell that they have an accessory pathway, and you only really find out at EP studies. So this is orthodromic AVRT with a concealed accessory pathway. Okay, so let's look at a 12-lead ECG of a patient with Wolff-Parkinson-White. Let's have a look at in V4. Look, they're in sinus rhythm, as you can see, but here we go, there is a P wave here with very little space between the end of the P wave and the start of the R wave, so the PR interval is short. Then we have a slurred, ugly upstroke to the start of the QRS complex. That's the delta wave. And if you look at the QRS morphology, it also looks wide and ugly. Now, this occurs because the atria is depolarizing as normal, but then the signal is sent to the ventricle early via the accessory pathway. This leads to the ventricle depolarizing in a non-usual fashion. So instead of depolarizing neatly via the fast bundle branches, it starts depolarizing slower from wider out, and then you get a wide QRS complex. Now, you can sometimes determine where the accessory pathway is located by the resting ECG. So in this example, you have a right bundle branch type of pattern here. So there's a RSR complex in V1 and dominant R waves in V2, and this likely tells us that this patient has a left accessory pathway because the right ventricle is depolarizing later than the left ventricle, giving a right bundle branch type pattern. Now remember that in Wolff-Parkinson-White disease you can depolarize directly from atria to ventricle via the accessory pathway. We have to avoid AV nodal blocking drugs in patients who can have that method of conduction, so antidromic arrhythmias, because if you block the AV node completely, then whatever the rhythm is in the atria can transmit directly to the ventricle without any slowing the AV node. So, for example, if you have atrial fibrillation in the atria, and remember that fibrillatory waves are 300 to 600 times per minute, then that means if that goes one-to-one to the ventricle, then the ventricle goes 300 to 600, and that, as you know, is bad. If you're ever concerned about a patient with Wolff-Parkinson-White in their arrhythmia, it's far safer to do a DC cardioversion after specialist advice. So let's talk about other regular narrow complex tachycardias. Next one is junctional tachycardia. Paroxysmal junctional tachycardia is very rare in adults. It's actually usually associated with underlying cardiac disease in children. Often they go very, very fast, and it's got quite a high morbidity associated with it. Non-paroxysmal junctional tachycardia usually is found in adults, and it's usually slower, between 70 to 120 beats per minute. Normally junctional tachycardia is associated with some sort of other underlying physiological disturbance. So usually the treatment is to ignore the junctional rhythm and to treat the cause. P waves can be either before the QRS or inverted in the inferior leads, because remember, if you're depolarizing from around the AV node, that atria will depolarize retrogradely, so the P wave will be upside down and also close to the QRS complex, because the signal is very close to the AV node when it's initiated. And P waves can also be very shortly after the QRS complex, and that shows you that there's some AV dissociation. This is just a little rhythm strip of a junctional tachycardia in a child, and here's a rhythm strip of junctional tachycardia in an adult showing the little P waves in the QRS complex. Okay, let's look at an ECG of our next regular narrow complex tachycardia. We look at our baseline and we see that indeed it is narrow and indeed it is regular, and the question is, are there P waves? Not absolutely certain that we can see P waves. There's certainly T waves, but not obviously P waves. So we go P hunting, and remember to go to V1 for that. So now we start seeing something that looks like a P wave and looks like a T wave. Now, really important to decide whether these are discrete different waves or whether they're the same. And if you look at the tops of the waves here, you'll find that they look absolutely exactly the same. The other thing you'll notice that the rate of these blips is identical. So there is very regular space between each of these blips. Then we're going to look at the rate, and the rate is approximately one blip every large square. So if you're on the same page, 300 beats per minute is going to be atrial flutter. Now the ventricular rate, because we'll be blocked at the AV node, will be 150. Let's just check. Two big squares between each R wave. So this is atrial flutter with 2-to-1 block. Here's another example of atrial flutter with 2-to-1 block, but the ventricular rate is actually sped up. Now remember what I said about flutter. The flutter waves can be from 260 to 360 beats per minute. So if we look at the flutter waves that are pretty obvious up here in V1, they're actually faster than once every big square. So this is actually flutter with a flutter rate of about 360, giving us a ventricular rate of 180. So this is the fastest flutter I've ever seen. So let's talk a little bit about atrial flutter again. The flutter waves can vary from 260 to 360 beats per minute. The ventricular rate is always a multiple of the flutter rate due to the block in the AV node. V1 is the best place to look for flutter waves. One rule of thumb is that exactly 150 beats per minute is flutter until proven otherwise. Often when you've got a patient on a monitor, an invariant ventricular rate gives it away. So usually with sinus rhythm, patients' rate will vary with deep breaths, with movement, with if they're excited or if they have pain, for example. Flutter will just be exactly 150 all the time. That's a big giveaway. So let's summarize our regular supraventricular or narrow complex tachycardias. Those with a long RP interval where we can see P waves is sinus tachycardia or atrial tachycardia, and remember to decide between these it's best to have a sinus rhythm ECG and we can see if the P wave morphology is the same in the tachycardia. There are the short RP tachycardias and P waves are often hidden. The most common is AVNRT, but there are also the AVRTs, of which Wolff-Parkinson-White is the variant we worry about, and also junctional tachycardia, and then where we see flutter waves, and that's going to be atrial flutter, and if it's regular, it's going to be a regular block. So that brings us to the end of the narrow complex tachycardias. So let's just go through a summary of what we've talked about. We've got a tachycardia, and first of all, we're deciding whether the patient is stable or unstable. Remember, if they're unstable, we're going to consider emergently cardioverting the patient, treating their electrolyte disturbance, and also considering a toxicological cause. If they're stable, we're going to ask ourselves, is it wide or narrow? Now, if it's wide, that's going to be the subject of the wide complex tachycardia talk, which I hope you'll listen to. But if it's narrow, then we decide whether it's regular or irregular. Then we look for the P waves and the morphology of the P waves. Within the regular tachycardias, we've got sinus tachycardia, atrial flutter, atrial tachycardia, junctional tachycardia, the SVTs, AVNRT and AVRT, and Wolff-Parkinson-White, which, as we say, is a variant of the AVRT. In the irregular tachycardias, we got atrial fibrillation, by far the most common, multifocal atrial tachycardia, flutter with variable block, sinus with ectopics, and again Wolff-Parkinson-White, which we'll talk about more in the wide complex talk. Thank you very much for listening to TiCME today, and I look forward to seeing you next time.